So my first story, I think, is a really good illustration of the value of primary care in one of primary care and family medicine's most important roles, and that is seeing the big picture, helping the patient not fall through the cracks of this complex system. So this is a 22-year-old female whom I saw in my addiction medicine practice because she was using Dilaudid, a common pain pill, it's very potent pain medicine for her sickle cell disease. She was on it chronically every day, and there were some recent concerns by family and maybe even by a provider that she was going through it too quickly. So the question comes up, is she addicted or what's going on with that? So her history is pretty significant. And at age 22, pretty sad. In addition to sickle cell disease, which most people know can be very painful and disabling, she also has asthma. And there was a suspected or questionable drug overdose at some point. It's unclear whether it was accidental, intentional. And she ended up having an intracranial hemorrhage, a bleed in her brain. She needed to be put on a breathing machine. She needed brain surgery. And this is in May of 2020. She ended up getting like a blood clot in one of the veins in her brain. She ended up getting subsequent seizures. She had blood clots in her legs and her lungs, more brain bleeding, and basically infarcts, basically strokes, just a lot of issues and some residual aphasia, some difficulty communicating verbally. When she speaks, it's very slow and deliberate, and some mild hemiparesis, some muscle issues and neurologic issues. She had further surgery months later and chronic, uncontrolled pain, and even a COVID infection in December 2020, finally discharged home. So just really, really sad. She's followed by a hematologist, a primary care provider through a different health system, and I don't know if she goes that often, pain management, speech pathology because of her aphasia. At one point, she even saw hospice and palliative care just to help advance care planning issues, neurosurgery, neurology, so a lot. So when I saw her, she was, of course, talking about her chronic pain in her hip, backs, even her skull because of the previous surgeries. She told me about what opioid medications she had been on in the past and what she's what she's taking now. Um, and we've talked about who had controlled her pain medicines. That was a really good pain management provider whom I know well, but that one just is no longer with the health system. So switched to a new pain management provider who I think got very worried about the extent of the opioids the patient was on, which is very common when a patient on chronic opioids gets a new provider. And when I saw the patient, there were concerns from her mother and brother regarding the use. There was a question of becoming dependent, that she's not functioning. She just sort of sits there like a zombie. Well, in my speaking with her, she has a history of some anxiety and depression, and she was taking a low dose of an anti-anxiety medicine, venlafaxine, also called Effexor, but she didn't really think it was helping. And she admitted she feels withdrawn sometimes, can't get out of bed, nightmares, poor sleep. And at once in April, during one of her admissions, she was seen briefly by psychiatry. There was a question of suicidality, but really turned out to not be the case. And the patient didn't want any interventions. During that visit, the psychiatry note said no physical abuse, that there was some trauma from parents divorced, and that the mom was embarrassed by the suicide attempt, if it was a suicide attempt. And turns out the patient did say years ago there was an episode where she went to a bridge and was going to jump off, but instead called 911. So she currently doesn't see psychiatry or counseling. And again, she was referred to us. So when I saw her for that initial visit, I got this complex history, no thoughts of hurting herself, no drug use, smoking or drinking, did go through her pain medicines more rapidly. She lives with her mom and her half brother. So it turns out when I did my basic history, she moved here from Sierra Leone in Africa at age 12. And when I asked her very directly about physical trauma in childhood, she said very matter-of-factly and very sullenly that she was beaten a lot. When I asked about sexual trauma, she was already very quiet, but she got even more quiet. She looked down and in a very flat affect said, "I do not want to talk about it." She became tearful, and of course, I didn't push the issue. Um, and I think this is just such a classic example. The elephant in the room is, of course, her previous trauma. And there's a very, very good chance that at least some of her opioid medications that she's using are to medicate anxiety and previous pain and trauma. Now, no doubt she has horrendous physical pain from her sickle cell and everything out. There's no question of that. And we need to treat that aggressively, possibly even with opioids. But here's someone who has seen pain management doctors for years. She saw at least once a psychiatrist for suicidality as a question. She sees multiple other providers. No one is looking, it appears, at the big picture of seeing really what's going on. Why is she so withdrawn? Why is she anxious? And of course, even the horrendous trauma aside, given the sickle cell and the medical issues, who wouldn't be traumatized and have anxiety? So my goal with her was to gain trust, was to validate what she's been through. And my goal is to get her to the next, I'll call it level of care. So I spoke with her about things, and I said, would she be willing to talk to someone about her chronic pain? Like a counselor, I know a good psychologist who really specializes in pain, chronic pain. She said yes. Well, it turns out this psychologist is also excellent with previous trauma. Certainly the patient needs, long-term needs both. There's so many family dynamics issues. The mom was ashamed of the suicidality. The mom doesn't think the patient should address or deal with anything with her previous trauma. Just very antithetical of how we in our health system, how we approach psychiatry and previous trauma, very antithetical of how we approach it. So my goal is to gain trust, get her to a good psychologist. She apparently needs some type of pelvic exam because she's going to be on some type of medicine where a baseline pelvic exam is warranted. So I told her I would get her to someone whom I trust, where I spoke with the gynecologist first, who can just talk to the patient first and get to know them. This is a gynecologist who also is board certified in family medicine. So also really gets that big picture. So to me, and when I think about this story, every time I tell this story, I just get frankly angry and sad that this is such a treatable but sad, lost case of this poor girl who just sits there with this blank stare, caught in the middle with no one taking ownership of the really big picture.
So Lee, that's a powerful story. Can I ask you? You commented that early on about conversations with or information from family members. How is it that you're engaged with those family members?
So on her, I want to say her first or second visit, she brought her stepbrother, the one who had concerns, because at her first visit, she didn't bring him in. I think he was in the car waiting. And one of the reasons she was referred to me was apparently her family had concerns. So I said to her, can you bring your brother or family member next time? Is it okay if we talk about this? To her credit, she did. And he came here. He was very nice. He was worried about her and her anxiety. And I asked about her medication use. And he said that he did think she was going through it too quickly. I did not bring up any detailed issues about her past or previous trauma. But it was nice that she seems to be engaged with her family. And I am more worried about her relationship with her mother, whom I have not met. But I think moving forward, getting the family involved, is, especially the brother and hopefully the mother on board regarding validating what she's been through. In my role currently as an addiction medicine specialist, unfortunately, I don't have the same relationship with her as if I were her regular family doctor. But again, at this point, she hasn't really seen one. And I'm hoping once we get her moving through the system that I can hook her up with a family doctor that I know who can really look into these issues.
Great. And in your opinion, you work a lot with addictionologists. How do you think most addictionologists who weren't family physicians, how do you think they would have, how would the care have been different?
I think most addictionologists who don't have that broad-based primary care, particularly family medicine background, I think would have addressed the opioid use, maybe would have managed that, maybe would have switched her to a medicine called buprenorphine, also called Suboxone, probably referred her to counseling, more likely related to the opioid, and called it a day. I think most addiction medicine specialists, like most specialists, are very busy and stick to what they know. And unfortunately, and I don't blame any one particular specialist, it's really truly a systems issue. We've created a system where when a patient goes to a specialist, it's for a one isolated question, and the specialist is busy and he or she needs to address that one question and go on to the next patient. So we don't have a system designed for specialists or subspecialists to take ownership. And sadly, more and more, we don't have a system designed for family doctors to do that because patients are going to urgent care or getting so fragmented. So again, this is big time systems issue as well as the training of the specialty.
So the likelihood of the family dynamics and the early childhood abuse most likely would not have been uncovered.
I would completely agree. And again, I mentioned all these other specialists, and I look through the record, the electronic medical record we have has a way that you can search text throughout the record. I searched the text for like trauma, abuse, things like that, and really did not find anything related to that. And and again, not just the trauma, but the family dynamic. Not only did this patient go through the trauma,
right,
but she's been told by her mom to not talk about it. So the internal shame that often comes with trauma, this has been magnified. So it's just a terrible situation.
I'll say. So do you want to go on to the second story?
Sure. So this is someone whom I just coincidentally saw this morning for follow-up. 62-year-old male, just a significant medical history, gastrointestinal issues, alcohol abuse, high blood pressure, cholesterol. But the other big issues, he had an aortic rupture a few years ago. So one of the largest blood vessels in the chest, and frankly, many people die from that because you can bleed to death so quickly. He was really miraculously saved by an excellent cardiothoracic surgeon at the hospital I know. And he's got chronic pain from a previous injury. He had a forklift accident like 20 or 30 years ago. He had terrible pneumonia. He was in the hospital, he says, for almost a year. He was sort of left as dead. I mean, he was very sick. He had this ruptured aneurysm about 5 years ago. So not surprisingly, anytime he gets any chest pain or anything like that, he is really worried. He's very anxious. He really, one of his drugs of choice were benzodiazepines, commonly used class of medicines for anxiety and very easy to get addicted to. He also was going through pain medications very quickly because of this chronic pain. He has a very flat affect, and it's unclear if it's because of his previous traumas and who knows what, but he's got terrible anxiety disorder. He may have been diagnosed with a schizoaffective disorder, sort of just a little bit of an odd character. But to his credit, he's a very smart guy. He knows exactly what's going on. And very sadly, I've seen this again and again and again in healthcare, where someone who has a flat affect, who speaks slowly, very analogous to the previous patient, or who may have some physical impairments, maybe a cerebral palsy. People sometimes, very sadly, healthcare providers blow these patients off, don't take them seriously, what would be their, minimize them, sort of almost an attitude of, oh, it's okay, sweetheart, that kind of an attitude. And I got the sense that that was happening with him. And as I got to know him, again, he's sharp as a tack. When I put him on the medicine buprenorphine, and he's been doing really well with that, he came in the next day and read up on it, had great questions, very insightful questions. Well, over the past year or two that I've gotten to know him, he's really opened up to me about his medical problems. And as a family doctor, despite my addiction medicine specialty now, it's very hard for me to keep focused on the addiction medicine. So sometimes I play doctor and look at the big picture. And, and really, I try to validate what he's going through with all of these different providers and also help him look at the big picture. For example, a couple months ago, he had had some life-threatening blood clots, and he was on a blood thinner for a few months. But recall I mentioned early on that his history, he had some very bad trauma. Oh, I apologize. I forgot to insert this. In January 2021, oh my gosh, I forgot to mention among the most important part. On his birthday in January, he lives alone and doesn't have family. He was going to the pharmacy where he gets his medicines to buy a popsicle from the freezer to celebrate his birthday. He was assaulted afterwards in front of the pharmacy to the point that he had a skull fracture, brain bleed, rib fractures. I mean, horrendous, horrendous. And so he has chronic pain from that and even more cognitive issues. And he needed to be in the hospital, then a physical rehab hospital. So now we're addressing that. So he had in addition to everything, a blood clot and was on blood thinners, which he was worried about given these brain bleeds, given his ruptured aorta. So this poor guy, and this is where I think primary care really shines, because the neurologist and neurosurgeon are going to appropriately say, hey, that blood thinner can cause a life-threatening bleed in the head. The blood expert, the hematologist, is going to say, you need that blood thinner or you're going to have more clots. The cardiothoracic surgeon is going to say, don't do the blood thinner. You're going to have a ruptured aorta again. So this poor patient's caught in the middle. And how do you navigate this? Well, that to me is the role of a good primary care provider. So I helped him talk about that. And subsequently, he's been seeing a family doctor in the past couple months who, and she is terrific. She's taken the time to get to know him and help him balance these questions. Now, she's hard pressed for time, like all primary care, but she does a great job communicating with the other doctors. So he trusts her, and he should, because she's clearly looking out for his big picture best interest. And as a full disclosure, she trained at the residency program where I was faculty at for a long time. But he now really has a great team of providers. But every time he comes in, we rarely talk about his drug abuse from the past, and he was really more of a misuse, and more about his other issues. And he always comes in and just says, "Oh, things are so bad." So I just listen, and I think he feels very appreciated. I mentioned someone where he can call our office and sometimes be a little challenging because he knows his stuff. But last holidays, over the winter holiday, he wrote each of us in the office a personalized thank you holiday card with this scribbled handwriting, very poor handwriting. You could tell he barely can write given his physical conditions, but it was so sweet. And it again just showed me yet again the importance of looking at the big picture, putting the pieces together, learning through family medicine that we don't always cure, but you could listen and validate. And if you can't cure, if you can't fix the issue, that's okay, as long as patients know you're trying and you're there for them. And I think the family medicine background I had really helped in his case for us to bond in that respect. So I think that's him.
Right. That's an incredible story. Amazing.
Yeah.
How about patient number 3?
Okay. So this is a 27-year-old female who started using opiates at around.
And by the way, Lee, if for some reason I drop off the line, it's because I'm going through the tunnels here in the western central Pennsylvania.
Okay.
Just go ahead and tell the story. Denise is staying in the background on the call, and she can manage things. But you just go ahead and tell the story.
Thanks for the heads up. No problem. So, so this is a 27-year-old female. She started using opiates at age 18, and she's been using heroin since age 25. I first met her about 2 years ago, and her longest sobriety had only been a few months. She had been using for about 4 years straight. When she came in to see us in the office, we were able to transition her to buprenorphine, Suboxone, a commonly used medication to help people stay sober from opioids. She's now on a monthly injectable version of buprenorphine. She's been completely sober for 2+ years now, so just wonderful. Maybe the second visit when I saw her, we talked more detail about her mental health history. And she talked about anxiety and insomnia, but she had a lot of symptoms that were very consistent with bipolar disorder. Now, you really can't make a diagnosis of bipolar or any other mental health disorder while someone is in active drug use, because the symptoms could be from drug use or withdrawal. But her history, it really suggested that. So I really wanted to get her into mental health experts, counselors, psychiatrists, which unfortunately can take a long, long time if you're lucky, if you can even get someone in. So because in family medicine, you get that broad-based training, and in family medicine, part of your formal training is in behavioral medicine, psychiatry, you do a lot of good rotations with that. I feel very comfortable managing psychotropic medications. And during my training in addiction medicine, I did some even more training in these psychiatric medications. But again, I think it was really building on the strong foundation I had. So I was able to get her started on some medicines while waiting for psychiatry, which took at least 6 months. Well, within a few short weeks, she was doing even better. She would come in and just say how great she felt and how good she was feeling. And I remember maybe a couple months into when I was seeing her, she came to a visit with her mom to get this injection. And I stopped, and it was actually just a nurse visit. And I stopped in the room just to say hi to the patient. Her mom was there. And her mom was just so sweet and complimentary and just saying how thrilled she was that her daughter's looking so good. And it was just so satisfying being able to just be a family doctor and address this issue and that issue. And she now sees psychiatry. She's doing pretty well. We still touch base about her psychotropics, and we'll talk about tweaking things, and she'll talk to her psychiatrist. But what's more, something else that jumped out at me about this, again with the family medicine background, was I'm going to say about 6 months ago, she was a little withdrawn, a little more upset than usual. And again, usually she's a little shy, but very open with me. And I asked what that's about. And it's COVID, so people are always wearing masks. Well, it turns out she's got significant hirsutism. In other words, she had a lot of hair growth. She basically had a small beard. And it was, not surprisingly, very, very upsetting to her. She's a sweet girl, she's a pretty girl. And so this was very troublesome to her. And she didn't know what to do. In fact, she was ashamed to talk about it. But because we had developed this open, trusting relationship, she told me more about it. And she told me more about irregular periods she was getting and some other issues related to sort of gynecologic concerns. In my background as a family doctor, I've done a lot of gynecology. I had delivered babies for several years. So I was very comfortable talking to her about these issues. And I said to her, listen, we need to get you in to doctors, who can do proper workups. But in the meantime, let me get this going for you. So I was able to order some basic hormonal tests and get the ball rolling. I even put her on some basic medications to try to get things started. And it turns out she's has this very rare condition. And I sent her even to a reproductive endocrinologist, basically a gynecologist with expertise specifically in hormones. And even she is a little stumped by what's going on. So I'm very glad that I was aggressive with her about ordering these blood tests and getting the follow-up tests and insisting she gets them. And it took a lot of phone calls to the lab to get them to order these specialized tests, but she really did need them. So she's in the process now trying to figure out what's going on. So on the one hand, the patient's still a little upset. You don't know what's going on, but she feels so much better every time I see her that we're moving in the right direction, that she's starting to get some answers, that she knows that we care and we're doing a workup and that it's okay. So again, I think that broad background of, I think this is a great example of how family medicine, the fact that we know a little bit from all different fields means we may not be experts in everything. In fact, we're not in most things. However, we are experts in getting the ball rolling, in getting things started, getting patients in the hands of people we trust. So I think this was a great example for this. And she also has been recently talking about an eating disorder that's flaring up. So again, that broad base. So, I think again, the trust issue that you learn in family medicine and the broad base, really medical, in this case, the mental health, medical, gynecology, endocrinology, I think made a big difference for her. And I think she's really thrilled with the care we've provided. And I would argue, again, it's because of the family medicine background.
It certainly seems that way to me. And again, these are just amazing stories. The complexity and the compassion and humanity are just remarkable.
Well, thanks. But as you and I have talked about for many years, Larry, these in some ways are very typical in family medicine. The challenge has been my frustration and yours many times is that family doctors many times don't give themselves credit for the complex work with these types of cases they're doing. There's really no other specialty in many respects who could do this kind of work, but we do it so often. It's such a core of what we are that we don't recognize how special it is and how much we're helping patients doing work that no one else can in many respects.
I absolutely agree. And Lee, what I'm going to do now is bring things to closure, and we'll get a draft of this. It'll take a few weeks. We've got our meeting coming up in early October, so my staff is going to be, and I am going to be tied up. But we'll get this to you as the first draft, and see if we can work this up. I think these are stories that need to be read very broadly.
Yeah, thanks. I think they're just great examples. And